Hello, and welcome to another live broadcast with MedStar Health. My name is Michelle Carter, and today we're discussing the unique differences that women experience with heart failure. Heart failure is a common cardiac diagnosis and one of the leading causes of hospitalization. There are gender differences in heart failure from its incidence, hospitalization rates, causes, and how and when it's diagnosed. So today we'll talk specifically about heart failure in women. We're joined today by four of our advanced heart failure cardiologists. I have Dr. Jennifer Brown, Dr. Erika Feller, Dr. Rania Kaoukis, and Dr. Maria Rodrigo. So stick around, share this broadcast with your friends and family, and give us a like to let us know that you're watching. And if you have any questions for our panel of experts, please share those in the comments below. We're going to take some time to answer those as well. So before we get into our questions, let's learn more about our experts. So I'll ask each of you, could you introduce yourself and explain the work you do at MedStar Health? I'll start with Dr. Jennifer Brown.
Hi, thanks so much for having me. I am an advanced heart failure cardiologist at MedStar Cardiology Associates in Annapolis, Maryland. And I work predominantly in our Annapolis office and also see patients in the hospital at Anne Arundel Medical Center.
Great, thank you very much for joining. Dr. Erika Feller.
Hi, everyone. Thank you so much for having me. It's great to be here. I'm also an advanced heart failure transplant VAD cardiologist. I'm based in the Baltimore region. My main clinics are at Union Memorial, but also I have community clinics in the Bel Air office as well as the Glen Burnie office. My central role is really as the medical director for outreach for the heart failure folks all around Maryland, DC, parts of Virginia, Delaware as well. Thanks again.
Of course, and thank you. Dr. Rania Kaoukis.
Thank you so much for having me. I am Rania Kaoukis. I am one of the advanced heart failure cardiologists, and I work primarily at MedStar Southern Maryland Hospital, where we have a heart failure clinic here. I also rotate inpatient as well as in clinic at Washington Hospital Center. I am the director of heart failure at MedStar Southern Maryland. Thank you.
Thank you. And Dr. Maria Rodrigo.
Yes, hi. Thank you so much for having me as well. I am also an advanced heart failure cardiologist. I'm the medical director for the heart transplant program here at MedStar Heart and Vascular Institute at Washington Hospital Center. I also lead the outpatient LVAC clinic. So my time is 100% at Washington Hospital Center, where I have been for over 10 years now.
That's amazing. Thank you very much. And thank you all for taking out the time to talk to our audience today. All right, so let's start with an overview of heart failure. Dr. Kaoukis, could you share what heart failure is?
Yes, so heart failure is a lifelong or chronic condition in which the heart muscle can't pump enough blood to meet the body's needs for blood and oxygen. So basically, the heart can't keep up with its workload. Heart failure can occur when the heart muscle is weaker or stiffer than it should be.
All right, thank you very much. Could you also explain ejection fraction and the role that it plays in heart failure?
Yes, so ejection fraction is a term that we use to describe how weak someone's heart muscle is. So every time the heart squeezes, it's supposed to squeeze out about 55 or 60% of the blood from the bottom left heart chamber out to the rest of the body. This 55 or 60% represents a normal ejection fraction. When this number is less than 55%, this may represent a weak heart muscle.
Thank you very much, Dr. Kaoukis. I'd like to turn to Dr. Brown. Could you share what are the most common risk factors for heart failure?
Sure. So the most common risk factors for heart failure include high blood pressure, coronary artery disease or atherosclerosis, diabetes, obstructive sleep apnea, obesity, certain toxins, so certainly alcohol, cocaine, chemotherapy, as well as other drugs are known to cause cardiotoxicity. Family history and genetics certainly plays a role. And then there are other infectious issues like HIV, even flu, COVID can cause something called a myocarditis and a more transient heart failure.
All right, thank you very much. I'd like to talk now about the gender differences and causes for heart failure. So Dr. Brown, could you share if there are any gender differences when it comes to the risk factors or prevalence of heart failure?
Sure. So the most common cause of heart failure in men is coronary artery disease or atherosclerosis, as previously mentioned. This is blockage in the heart arteries that comes from many of the risk factors we mentioned, whereas the most common cause for women tends to be high blood pressure and diabetes. Women tend to have more of a stiff heart. This is called diastolic heart failure. Of course, there are many women with systolic heart failure as well, but predominantly more women with hearts that are stiff, whereas men tend to have more of a weak heart. And again, this often occurs most commonly from blockages in heart arteries. Also, we tend to see that women with heart failure survive longer than men and have a lower risk of sudden cardiac death.
That's really interesting. Could you share, do women tend to develop heart failure at the same age as men or earlier or later?
Yeah, so in general, heart failure is a disease of people as they age and more common in adults over 65. But we do see that men tend to develop heart disease earlier than women. And this may be due in part to the fact that women, when they are younger, are somewhat protected by estrogen and progesterone. And then once women reach menopause, we tend to see the risk of heart disease and heart attacks increase. Average age for a first heart attack in men is 65, whereas women in 72. And while we're not talking about coronary artery disease today, we do know this is a very common risk factor for heart failure and may be one of the reasons that we see heart failure develop a bit later in women. Additionally, as I mentioned, this is a aging process or a disease that we see more commonly as people age.
That's all very interesting. So turning now to Dr. Kaoukis, could you share, are there any warning signs or symptoms for heart failure that show up different in women versus men?
Yeah, so as Dr. Brown alluded to, men sometimes tend to have more coronary artery disease, so symptoms of chest discomfort or trouble breathing related to coronary disease may be more common in men. However, symptoms of heart failure like shortness of breath with rest or with activity, difficulty lying flat because of shortness of breath, swelling in the legs or in the abdomen, or feeling full after eating small meals. These can be symptoms of heart failure across genders. So although these are not clear gender differences in regards to these symptoms, some symptoms may be more prominent in some individuals compared to others.
Okay. And back to Dr. Feller, could you share how does menopause factor into increasing a woman's risk for heart failure? Could you explain how that change in hormones affects women? I think even Dr. Brown sort of shared a little bit about this after, as women age, our risk factors could increase.
As women age, the estrogen levels go down, and that can start, in the 40s, definitely in the 50s. And, we know that when estrogen decreases, you sort of decrease that protection. And what that does exactly is it decreases sort of the endothelial health, so the inside of the arteries. And what that leads to over time is changes in blood pressure. So blood pressure actually goes up most of the time as estrogen goes down. So during menopause and even peri or premenopause. The other thing that happens that estrogen helps with, and so a lack of estrogen hurts changes with insulin handling. So glucose changes and glucose overall increases. And not that everyone develops diabetes, but it's, the even small changes in glucose and hyperglycemia can add to the risk of coronary artery disease, and then, of course, heart failure. Other things that can happen are changes in lipid profile, so your cholesterol levels can increase. And that's another protective mechanism that estrogen carries with it, is keeping lipid levels better controlled anyway than postmenopause. So those are the big things that change in even in most women in their 40s. You start to see these changes.
Thank you, Dr. Feller. Turning to Dr. Rodrigo now, can you explain what peripartum cardiomyopathy is and how it can impact heart failure even after pregnancy?
Sure. So peripartum cardiomyopathy is obviously a type of heart failure that is going to be unique to women. And it's this dysfunction of the muscle of the heart that occurs late in pregnancy or early in the few months after the delivery, when there's no other causes that can be identified for heart failure. So the definition used to be a little more restrictive before, where we would say that it was a patient that developed it the last month of pregnancy or the first 5 months post-delivery, but that definition has been broadened. We know that patients can present late in pregnancy, but maybe 2 months before the delivery. Whereas those women who become pregnant and have an underlying cardiac condition that has been diagnosed before, their trouble tends to start more in the second trimester, when there's more shifts, hemodynamic shifts and fluid shifts. So this occurs later in pregnancy or even after delivery, many times diagnosed the first month after delivery. One of the tricky parts of the cardiomyopathy is that a lot of the symptoms of heart failure that we've mentioned some during the session today can really mimic symptoms of normal pregnancy. So everybody who's been pregnant before can tell that you might feel a little short of breath, you may feel bloated, you may feel tired, you may have swelling of your legs, right? And you might just attribute that to normal pregnancy changes. And that's why there has to be a high clinical suspicion by the physicians and cardiologists to be able to really understand when something is outside the typical pregnancy symptoms. And when that suspicion is there, then to look for that diagnosis. And the way you look for that is with an echocardiogram. And so like Dr. Kaoukis already described, ejection fraction, the normal ejection fraction is around 55–60%. With women with peripartum cardiomyopathy, the ejection fraction drops below 45%. So you would confirm that by echocardiogram when you have the high clinical suspicion. And the important thing about this discovering the diagnosis is that you might be able to prevent complications that if you're diagnosed late, you may not be able to prevent them. The course can be variable. You can have complete recovery of your heart failure, or the heart failure can persist and can actually get worse, and in some cases require advanced heart failure therapies, meaning surgeries of either a heart transplant or a heart pump. You can also have rhythm issues, arrhythmias, electrical problems in the heart, or thromboembolic events, which are clotting events, and unfortunately, many times death. So what puts women in high risk for peripartum cardiomyopathy? The etiology is not completely understood, and there's a lot of suggestions of things that could be contributing, and it's possibly multifactorial. But we do know that women who are of African American ancestry, they do have increased risk of developing a peripartum cardiomyopathy, and their outcomes can actually be worse. Also, women of advanced maternal age during pregnancy, so those women that are over the age of 30 during pregnancy, or who develop hypertensive disorders or preeclampsia during pregnancy, or those patients with multigestational, like they have a lot of multiple babies pregnancies, which we see more now, that there's a lot of fertility techniques as well. So those are things that will predispose you to developing the condition. Another than African American having a worse outcome, also if at the time of diagnosis the ejection fraction is very low, that's also a sign of a worse outcome. Or sometimes when the left side of the heart, the left ventricle, is very dilated, that is also a worse prognostic indicator at the time of diagnosis. And that's why it's important to try to diagnose this early.
very important information. Thank you very much for sharing that, Dr. Rodrigo. Turning to Dr. Feller, from a physiological perspective, what are some of the differences in women that may increase their chances of heart failure?
Sure. So women's hearts generally are smaller than men. So the LV mass, or the left ventricular mass, generally is smaller. The other thing is that the wall thickness of the walls of the left ventricle and the right ventricle are generally thinner. So they have less hypertrophy over time, but they also have, again, thinner walls. So those are two key sort of differences. The other thing is that the arteries, the coronary arteries, so the arteries that supply blood to the heart muscle, many times are smaller, thinner, and what we call the secondary and tertiary vessels, so the smaller little tiny vessels going to the heart muscle, in some instances in women more than men, are not just smaller, but there are fewer of them. And so when you take all of those differences sort of together, what we think, and a lot of these theories have been shown in data, physiology data, is that the women's heart may be sort of more susceptible to higher blood pressures and differences in coronary flow or blood flow down the coronary arteries. And what that really means is hearts in women, or women's hearts, may be more susceptible and damaged faster with things like high blood pressure or even more minor coronary artery disease. And in total, that means that it's certainly possible. And again, we've seen this in a lot of the data sets, that women's hearts get damaged to the point of having a cardiomyopathy and then resulting heart failure from those differences in the physiology and the pathophysiology of women's hearts.
That's really interesting. Thank you very much, Dr. Feller. Dr. Kaoukis, could you share, is there a specific type of heart failure that is more common in women compared to men, and why is that?
Yes, so we've mentioned a few of these up to this point. So as we said, men are more likely to have heart failure related to coronary artery disease or blockages in their heart arteries. We call this ischemic cardiomyopathy. Women, especially elderly women, are more likely to have what we call heart failure with preserved ejection fraction or diastolic dysfunction, as Dr. Brown mentioned, where the squeeze function of the heart is normal, but the heart becomes stiff with age. This can occur in the presence of other risk factors, as we mentioned before, things like high blood pressure, obesity, and diabetes. We mentioned peripartum cardiomyopathy, and Dr. Rodrigo did a nice summary of that. That's unique, obviously, to women as it occurs during or after pregnancy. And one more entity I'd like to mention is Takotsubo cardiomyopathy, sometimes called broken heart syndrome. It's a diagnosis that occurs more commonly in women than men. This is an acute cause of a weak heart that can occur after an extreme or a stressful event, like the death of a loved one, for example.
Wow, yeah, I've heard of that last one. Definitely. This is just taking all this information in, very important information to know. Dr. Kaoukis, again, what can women do specifically to help reduce their risk for these types of heart failure?
Certainly, if you have heart disease or related heart conditions like high blood pressure or high cholesterol, making sure that you have ongoing care and adherence to your prescribed medications would be really important. Things like statin medications to control your cholesterol, blood pressure medications for your blood pressure, and of course, appropriate management for diabetes and sleep apnea. Also making sure to follow a heart healthy diet. Obesity control is really important as that is a major risk factor as well. And smoking is also a large risk factor in the damage of arteries in the heart, which can cause coronary artery disease and also heart failure. So staying clear of tobacco use is also important.
All right, thank you very much for sharing that. Let's talk about diagnosis. Dr. Kaoukis, could you share how is heart failure diagnosed, and how does the diagnosis differ for women, like different tests?
So there's no one test to diagnose heart failure. Your doctor will consider your medical history, your family history, a physical exam, and the results of various tests. These tests can include things like an EKG, which is the rhythm of the heart to see if, for example, there are any abnormal heart rhythms or evidence of prior heart attack. They may do a chest x-ray to see the size of the heart and to see if there's any damage to the lungs. Dr. Rodrigo mentioned an echocardiogram, which is a heart ultrasound. This is a test where we can look at the squeeze function of the heart and identify the ejection fraction that we talked about previously. There are also other advanced imaging tests like cardiac MRI. This can show the heart's structure and take a better look at the heart muscle itself, how the valves work, and the sizes of the chambers of the heart. An MRI can also help us identify reasons why your heart may be weak. And lastly, there are other tests to evaluate for coronary artery disease. Things like stress testing or heart catheterizations may be necessary if there is concern for underlying coronary disease.
Thank you very much, Dr. Kaoukis. Turning to Dr. Brown now, are the results for women and men interpreted the same for heart failure? Are there any gender-related factors involved in diagnosing heart failure?
Sure, good question. So as Dr. Feller mentioned, women tend to have smaller hearts. So our normal values for heart size, of course, differ between men and women. So when we're interpreting many of these imaging studies, as Dr. Kaoukis mentioned, such as echocardiograms, ultrasounds of the heart, or cardiac MRIs, or even cardiac CT scans, when we look for what is normal, obviously for a woman, having a smaller heart is going to be normal. So our concerns increase for women earlier if their hearts are bigger. And so what might be big for a woman could be, still in a normal range for a man. The other thing is that some of the stress testing that Dr. Kaoukis mentioned that we use to determine the presence of underlying blockages in the heart arteries can have some different degrees of artifacts that vary from men to women. So one example of this, a common test that your cardiologist might order is an exercise treadmill test, where we would have you get on a treadmill and walk and monitor your EKG with exercise. Women can tend to have some what we would call non-specific changes on their EKG that don't often mean very much, that are benign, but can sometimes suggest blockages. So it might be harder to interpret that test in a woman compared to a man. Additionally, another test we do to look for blockages called a nuclear stress test, where we look at the blood flow to the heart muscle. And we can see artifact on these tests from breast tissue. Sometimes the breast tissue sits in front of the heart muscle, and that can create a shadow that can make it harder to interpret the results on occasion. And additionally, this is true of both genders, but obesity can also cause artifact on our diagnostic testing. So we have to keep that in mind as well.
Thank you very much for explaining that. Dr. Brown, could you also briefly share the different stages of heart failure?
Sure. So when we classify heart failure, we look at both the stages of heart failure and the classes of heart failure. And I'll briefly discuss them both, because these are common terms that your cardiologist will discuss with you as they are describing your overall prognosis and severity of your condition. So stage A refers to patients that are at high risk for heart failure, but without structural heart disease or symptoms of heart failure. So an example of this would be if you have high blood pressure, then you have stage A heart failure. And I'm sure this is probably a surprise for most women listening to this broadcast, because many of us think of hypertension or high blood pressure as being somewhat of a benign diagnosis. My doctor put me on medicine, it's being treated. But the truth is, high blood pressure is really not benign at all, and making sure that it's very aggressively managed so that you do not develop heart failure down the road is really important. Stage B heart failure is going to be structural heart disease, but without signs or symptoms of heart failure. So one example of this might be if you have high blood pressure and your doctor orders an echocardiogram or an ultrasound of the heart to evaluate the structure of your heart. And we might see that the heart walls have gotten thick because of the effect of high blood pressure on the heart over years. So this is, again, very concerning. Not only now does the patient have high blood pressure, but they also have signs on their echo that the heart is suffering from the effects of high blood pressure. Stage C is structural heart disease with prior or current symptoms of heart failure. So once a patient starts to develop shortness of breath, decreased stamina, feeling like they can't keep up with their activities, swelling in the ankles, sometimes a cough or inability to lie flat, and certainly a hospitalization for a heart failure. These patients we all consider to be stage C. Stage D is really our end stage refractory heart failure. These folks are really at an advanced stage. Our routine guideline-derived medical therapy, which we'll discuss briefly, is no longer effective for these patients to keep them out of the hospital. And we have to consider things more advanced, which we will talk about later in the broadcast, like heart transplant and left ventricular assist device. I did also wanted to mention the classes of heart failure, because this is different. The classes of heart failure are more symptom related. So class 1 patients are without symptoms. Class 2 patients have symptoms, but with considerable exertion, with minimal exertion, with considerable exertion. For example, like walking several blocks, then they start to get short of breath or even farther. Whereas class 3 is going to be patients that have shortness of breath with minimal exertion. So just going from one side of the room to the other, for example, or going up a flight of stairs or half a flight of stairs. And stage 4 are going to be our patients that have symptoms at rest. So patients that are short of breath, just sitting in their chair, speaking, very minimal activity.
Thank you very much for sharing all of that important information, Dr. Brown. At this time, I'd like to take a moment and welcome our viewers again. Thank you very much for tuning in. We have a few questions that we'd like to address. Today, we're talking about heart failure in women. So far, we've covered gender differences, causes, risk factors, diagnosis, but we have much more to discuss. So keep watching, give us a like to let us know that you're here. And if you have any questions or feedback for our experts here, please share those in the comments. So first, let me start with a few of our audience questions. So we have one from Kathy. She writes, with HCM patients, and I believe that's hypertrophic cardiomyopathy, are there any certain jobs or careers that are not safe for women? Anyone would like to take a stab at that?
I can
start. Go ahead, Erika. Feller, you go ahead.
Yeah, I mean, for the hypertrophs, that's sort of a class of cardiomyopathy, where generally speaking, the walls of the left ventricle are thicker than normal. And there's a certain type of hypertroph that's also called obstructive. And that's when the walls get so thick and the cavity where the blood goes is so small that it's the amount of blood coming out to the heart, to the rest of the body, is decreased. And so any type of activity that exacerbates that, so either increases the heart rate, increases the load on the heart, can be difficult for patients. And those are really things that are, higher activity types of jobs. So climbing a lot of stairs, a lot of heat, a lot of cold, high energy, high activity would be difficult for those patients in terms of symptoms. So there's nothing real specific, but anything that would require that kind of activity level, again, should be avoided in hypertroph patients.
And along those lines, competitive sports, if it's a job that, does require that increased physical activity, like Dr. Feller is mentioning, not necessarily unique to women, but that is when people with hypertrophic obstructive
Thank you very much, Dr. Feller and Dr. Rodrigo. We have enough time for another question. This one comes from Sharon. What are alternatives to statins for women? She says, I've read that women over 60 should be aware of the side effects.
I'm happy to take that one. So
Okay.
I think this is a really important discussion to have with your cardiologist. In general, most people, majority of people, men and women, tolerate statin therapy, and it is extraordinarily effective, reduces morbidity and mortality, reduces the risk of cardiac events. So a really important class of medications that we use. And I think a lot of times fear over potential side effects can get in the way of optimal care for patients. And this isn't just related to statins. I think this is true of all medicines. And so in general, I would recommend just a really honest conversation with your doctor. There's no, everybody understands a concern about a potential side effect, but I think if you are at risk for heart disease and at risk for heart failure, statins are a great place to start. They are very effective, more effective than a lot of the other oral agents. Fortunately, we do have a lot of alternatives now that are predominantly injectable agents, and they're really very effective as well. Many can be taken every 2 weeks, for example. There's another one that is twice a year. Patients that have a concern about taking an injectable medicine, this would not be a great option for, but particularly for our patients that have intolerance to statin therapy, there are multiple injectable agents that we can offer. But I usually do not, and I'd love to hear from the other panelists about their practice, but I usually don't go to them first. I usually always try a patient on a statin. We can start on a low dose. We can add CoQ10. There's blood work that we check routinely every 3 months to 6 months to make sure the liver is stable on the statins and the muscle enzymes are stable. So I think in general, I would not have a fear of statins. They're a wonderful class of medicines, and majority of patients tolerate them without complication.
Yeah, I'm going to jump in again there. I think Dr. Brown's points are extremely important. I think people do tend to back off statins a bit too early. And like Dr. Brown said, the benefits are really great. And so we really, as cardiologists, should try to maximize the chances of someone getting on a statin. There are multiple different statins, and it's incredible to see how people can tolerate one or the other differently. So another way of doing it is you can start small doses, like Dr. Brown mentioned. You can actually switch from one statin to the other, and you can see that people may tolerate one over the other a lot more. And coenzyme Q10, like you mentioned, has helped us people as well. But I think it is important to put the message out there to try to be aggressive to get those drugs on. Maybe it's a little bit of muscle pain or a little bit of joint pain if it can be tolerated or managed by switching to statin. That is my preference too before jumping to any other drugs.
I agree with my my colleagues 100%. I think we have the tendency to stop them too quickly sometimes. So like Dr. Rodrigo was saying, a little bit of joint pain, a little bit of muscle aches isn't, necessarily a good reason to stop. They're very effective. Many of them have pleiotropic effects on the endothelial or the inside lining of the arteries, which again is really key to help prevent coronary artery disease. So you really have to have a high index of, let's try to stay on this because, again, risks versus benefits. The benefits, most of the time with a statin outweigh the risks, which are relatively small over time with these medications.
I wanted to say one more thing, which is that a lot of patients have joint and muscle aches at baseline before they even start a statin. There are conditions like fibromyalgia or osteoarthritis or lupus, rheumatoid arthritis. And I think it's important that a patient be very honest with themselves about what amount of discomfort they already have and what is actually due to the statin. And I think, unfortunately, a lot of people end up withdrawing from statin therapy because of a condition that is unrelated to the statin altogether. And so I recommend patients keep a diary. And if your doctor's starting you on a medicine, document to yourself what your symptoms are prior to the medicine, because a lot of times many of this joint discomfort and muscle aches was present even before.
Really good point, and great advice from all of you. Thank you very much for addressing those questions, and thanks to our viewers for watching and sharing your questions with us. At this time, I'd like to talk about some of the treatments for heart failure. So Dr. Brown, are heart failure treatments tailored specifically for gender to account for some of the differences of how heart failure shows up in men versus women?
So not really. The good news is our medical treatment for heart failure is fantastic. This is a very exciting time to be a heart failure physician, because our treatments for heart failure are better than they ever have been. And we're seeing patients have better outcomes than they've ever had. So what's really important is determining the type of heart failure. So we have talked both about systolic heart failure with a weak pump, versus heart failure with a preserved ejection fraction, or heart failure with a strong heart. So most of our treatments differ based on that divergence. So patients with a weak heart, there are many medicines, 4 pillars of heart failure that your cardiologist will want you to go on. Those classes are beta blockers, mineralocorticoid receptor antagonists, ACE inhibitors, or angiotensin receptor blockers, or ARNIs. Some of you may have heard of a medicine called Entresto. And then the last class is SGLT2 inhibitors like Farxiga and Jardiance. So your doctor will want you on all 4 of those medicines, because those patients have by far the best outcomes. They've been shown to stay out of the hospital, to live longer, their weak hearts get stronger. So it's really, really important that you're on those 4 medicines. For heart failure with a strong heart, or diastolic heart failure, unfortunately, there are less treatment options, but in the field, we're really excited because we finally have one class of medicines that has been shown to improve morbidity and mortality in those patients, and that's the SGLT2 inhibitors like Farxiga and Jardiance. I will say, in addition to those medicines, your doctor may want you on a diuretic like Lasix, furosemide, torsemide, Bumex are some possible choices that they might offer you to help keep the fluid off. So in general, there's really not medicines that are geared men towards women, but getting to the cause of the heart failure. So if a patient has coronary disease, of course, making sure that we're treating the underlying risk factors, true as well if it's high blood pressure, or certainly if there is a cardiotoxicity, removing that toxin.
Thank you very much, Dr. Brown. Dr. Feller, from a medication perspective, could you share about how women metabolize medications, and how there may be adjustments for that, or if there are any certain medications that women should avoid?
Sure. Yeah. I mean, this is a growing area, sort of the pharmacokinetics of some of these medications and gender differences. So one of the things we know about women, again, in general, the gender differences is women have a lower blood volume or plasma cell volume, just generally. GFRs are lower, and that's sort of the filtration rate of the kidneys, which is how many of these medications are excreted or metabolized. And we also know, and again, this is sort of more recent information or data, that the way that these medications and a lot of other medications as well become what we call bioavailable, so how the medication becomes sort of active in a person, is different in women because of the pH of the GI tract in women is different than men. And that's in many ways how these medications again become active. And so whereas we don't specifically look at one of the heart failure medications and say, okay, my patient is a woman, I'm going to dose it differently because you're a woman versus a man. I think what we're looking at is not just the side effects that they may have from the medications may be different, but also how they tolerate them and also how do they react to them. So it may be that a dose in a certain medication that would be good to start off in a male patient may be different than a female. And whereas we look at each of our patients individually, no matter what gender they are, and try to sort of optimize their medications based on how they're responding and the side effects, there's a growing body of knowledge that suggests really that the way women metabolize and also excrete these medications is different. And I think that really needs to be taken into account when you're looking at your female patients and trying to dose them with, sort of these 4 pillars of medications we've been talking about, and the side effects that may come with them.
Thank you very much, Dr. Feller. Turning to Dr. Rodrigo, on the heart failure spectrum, when is surgery indicated for a heart failure patient?
Right. So we've been talking about great treatments that we do have available for heart failure, which are these 4 pillars of drugs. Unfortunately, they do work many times, but in other times they don't, right? So when those medications are no longer working, patients are continuously having symptoms, they're having decompensations, they're having multiple hospitalizations, or they're having to come down on the doses of the medications, showing that they're not tolerating the medications as well. Those are signs that the heart failure has advanced. And it's important for patients to be educated on that. It's not a good thing that your Entresto dose is coming down or your beta blocker dose is coming down. Something's happening, that your blood pressure is lower on the medication, that you're not able to tolerate them. That could be a sign that your heart failure has progressed beyond a point where we can help with just pills. So in those cases, again, the diagnosis and the clinical suspicion early is key in determining how your outcomes are going to be as well. It's important for us as advanced heart failure cardiologists to be able to see those patients in a timely manner. 2 important tests that we do to try to see where that patient stands and whether they're a candidate at this point for an advanced heart failure surgical therapy are, one is a cardiopulmonary stress test. So again, a different type of stress test, this time where we measure what's called peak oxygen consumption. And it really tells us the true limitations from a cardiovascular standpoint that a patient has and could point towards letting us know that that patient's already ready for one of those surgeries. The other important test is a right heart catheterization. That catheterization is different than the one we do when someone has a heart attack. It's a catheterization where we measure the pressures inside the heart and we measure how much blood flow is actually being pumped out from the heart to the rest of the body. When that amount of blood flow is low and you're not tolerating these medications, then that is a sign that we need to do something else. And we need to start thinking of advanced surgical therapies. Oftentimes, we'll put patients on an IV medication to try to help the heart squeeze better and try to pump more blood out, but that's only a temporary measure. So this is not a solution. It's not going to cure the heart failure, but it's going to give us some time to improve the way patients are feeling, the way the blood flow is getting to the organs while we prepare for one of those surgeries. In terms of the options for surgery, if you want me to go into that, one of them would be a heart pump called the left ventricular assist device, and the other would be a heart transplantation. What that means is they're both open heart surgery, and very simply, in heart transplant, the sick heart comes out and a new heart is put in place. With the LVAD, the left ventricular assist device, the heart stays in place, but there's a hole that's cut in the left ventricle at the apex of the heart, and then the metallic pump is attached to the heart and sort of takes over the function of the heart, mainly the left side, the function of the left side of the heart. And while the pump stays inside in the body, there is a connection towards the outside. So there's something called a drive line that comes out of the belly, and it's connected to a controller that has batteries. So that's basically, in simple terms, what the 2 surgical options would be for these patients with advanced heart failure.
Can I mention one other thing, if you don't mind?
Sure.
So there are also patients that have heart failure from valve disease. And sometimes your doctor will recommend that you have your valve repaired or replaced. So that's another surgery that we sometimes consider for patients with heart failure. And then also, if you have blockages in your arteries, your doctor might recommend that you get bypass surgery. So prior to getting to the advanced stages that Dr. Rodrigo so expertly explained to us, there are other surgeries that a patient with heart failure might need if there is valvular disease or significant coronary artery disease.
Thank you very much, Dr. Rodrigo and Dr. Brown. At this time, I'd like to turn to Dr. Feller and talk about research and clinical trials. So what heart failure clinical trials are underway and what advances are on the horizon in terms of treatments?
Sure. So just for a little background and just to sort of describe the differences in how men and women were studied in the past and then into the future. The women's role in as they've been in research trials has been actually pretty poor over the years. So in any of these big trials, not just with medications, but also LVAD or the mechanical pump therapy treatments, and even some of the heart transplant trials, women were only enrolling, 20 to 30% in those trials. So, women were not well represented in a lot of the big trials. And probably the reason for that, going back to sort of look at that, is many women were excluded for pregnancy risk and the possible effects of new medications on the fetus. So that took out, a huge range of women from early trials. So if you were in, pregnancy capable range, age of 18 to 55, you were excluded from many of those early trials. So that was one of the reasons just, 10, 20 years ago that women hadn't been well represented. The other thing, just when you think of the trials and gender differences, is that many women, and again, this is a little bit of a generalization, but has been shown in a lot of the big trials, came to trials with more symptoms and more progressive or end stage disease. And so when they compared in some of the sub-studies, men's outcomes versus women's outcomes for some of these, women trended or did worse with the therapy that they were studying. And, that was something that the sub-studies really made clear. Then when we looked back, that again, women came with more disease burden for the most part in these trials. So that has changed to some degree. And I think the thing that we're looking forward to in some of the trials ongoing are actually more in the HFpEF trials. So the heart failure with preserved ejection fraction or the diastolic dysfunction, where the ejection fraction is normal or near normal. And most of the studies that actually I think that I'm looking forward to right now are in that group of patients. Because as we've all sort of discussed on this panel, we have fewer options for those patients. More so are women than men. They're more sort of targets, it seems to me, of intervention. And so some of the trials ongoing that, data should be released in the next year to 2 years are ways to look at how to treat not just the risk factors for those patients, but once they do develop heart failure, how to treat them and more specifically. So that's sort of one big category. The second sort of big category that I wanted to mention that we're looking forward to is how to monitor more precisely early stages of heart failure. So these are patients that have risks, but are sort of in the, the not real sick, but, maybe mild symptoms. as Dr. Brown kind of pointed out in the stages and the classes. And so we think that if we sort of target those patients before they have really overt symptoms, we may be able to not only sort of extend their life, but also extend their, symptom-free time frame. And so the trials we're looking at is monitoring, and most of these, the ways we look at this are sort of their cavity, their thoracic cavity pressures, which is really sort of their filling pressures or their fluid balance. And so that data should be out in the next 6 months for early stages of that kind of monitoring system. So we're looking at that to come out. We're also looking at some different types of medical therapy to target different areas, primarily of fluid balance, heart rate, as well as different, and other targets for patients with congestive heart failure.
Really interesting. Thank you very much for sharing all that's happening on this frontier of heart failure treatment. So you know what, that concludes our discussion for today. I really appreciate our viewers for tuning in and sharing your questions with us. We will take time to address those offline. Thank you again. Also to our panel of experts, Dr. Kaoukis, Dr. Brown, Dr. Rodrigo, Dr. Feller, thank you very much for taking out the time to speak with us today. For more information, or if you'd like to schedule an appointment with one of our advanced heart failure physicians, please visit the link in the comments. Thanks again very much and have a great day.
Thank you.
Thank you.